Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hi and welcome to EHA Unplugged. I'm Sarah de Vlieger, the Head of Education here at EHA. I'm very lucky today to be joined by Professor Carl June, very eminent CAR-T specialist. Professor June, would you like to introduce yourself, please?
Thanks, Sarah. I'm Carl June. I'm at the University of Pennsylvania, where I'm the director of the Center for Cellular Immunotherapies.
Okay. And we're really here to talk about sort of where we think CAR-T cell therapy is going. We've made massive progress in the last few years, but obviously there's also new exciting things on the horizon. Would you care to sum up some of the things that you see coming in the future?
Sure. Well, yesterday I presented, and what we now have is, in both pediatric and adult patients, 10 years or more of follow-up. And we know now that, when we started this, we were giving an acquired immunodeficiency to patients. We were taking away B cells or other cells, and we didn't know if there could be long-term complications from that. And now with a decade or more of follow-up, we haven't seen that. And we know that, patients can have durable remissions and very little long-term side effects. So I think that means there's a very bright future for cell therapies. And at this meeting, we're seeing huge innovation, extending the reach of where CAR T cells go to earlier lines of therapy. And many innovations in next generation CAR cells that are at this point, still in preclinical testing, but they look really promising that, that we'll see more and more both enhanced efficacy and increased safety.
So one of the big discussions around CAR therapies in general in Europe is obviously the cost associated with it, also considering the time vein to vein. In your talk yesterday, you were talking about this move towards potentially an off-the-shelf CAR T cell therapy. How do you see that rolling out?
Well, I think we're going to have both as an ongoing tool autologous CAR cells and then off-the-shelf cells. Mm-hmm. And one reason for the use of autologous cells is very well demonstrated safety profile and the ability to have long-term persistence. But the real issue now with autologous cells is, as you mentioned, the vein-to-vein time, so making so that they can be made readily available. We now have 2 trials at the University of Pennsylvania where the CAR T cell manufacturing is 3 days long, and Novartis has a trial with 2-day manufacturing, and in China they have trials with 1-day manufacturing, so it's getting much shorter, which really is much better for the patients and the physicians. A big topic of conversation at this meeting has been what bridging therapy there should be. And if you really don't have to worry about a large gap, that becomes less of an issue if the vein-to-vein time becomes very short. And I showed data yesterday of a patient who had a complete remission after a total infusion of only 3 million CAR cells. And that's the normal dose we give to a mouse. It's about 100 times lower than the dose of the current, commercially approved CAR cells. So that 4th generation CAR cell is much more potent, and it may even be possible, we think then, so that the CAR T cells could be manufactured by just a simple phlebotomy or blood draw and not have to go through the apheresis procedure.
That would be wonderful. Do you also see a concomitant reduction in side effects with the lower load of CAR cells?
The answer to that is no. So what we see is a shift to the right if you look at the curve of concentration over time. So with a very small dose, the patient is literally becoming like the bioreactor. And with a short-term manufacturing, not much proliferation occurs. In the laboratory, it's all in the patient. So what we see is the time, if there are side effects like cytokine release syndrome, it occurs later than it does with the current second generation CAR T cells.
And how do you think that will impact service delivery to patients if we're moving in that direction?
So I think what we're going to have is over the say next 5 years is complete automation of manufacturing. And so right now, all of the commercially prepared CAR T cells are made with human labor, which is costly. And but if it becomes automated, I think we'll have more consistency and the cost of goods goes down, which is a major barrier. Is just the cost of these therapies. And I think that we're also going to have, as the regulatory authorities get more used to what CAR T cells can do, I think we'll start seeing more point of care manufacturing right at the local hospital. And that will then remove the complicated and complex logistics of shipping back and forth to a centralized manufacturing center.
Yeah. So in Europe, we already see a slight trend towards some academic manufacturing. Are you also seeing that in the US, or is that not happening?
Yeah, well, yes. I think at our center at the University of Pennsylvania, we have an approximately equal, about 50% of our CAR T cell patients are treated with commercial products and 50% on academic trials. I think it's really good that we can have academic trials to make next generation CAR cells. But hopefully, the manufacturing is going to become more at the center, and with short turnaround. I think everyone will benefit from that.
And as we move into patients who are 10 years out from, 10 years in remission, are there any additional things that are popping up, long-term side effects that weren't anticipated at the beginning?
Well, so far we have not seen long-term side effects. I mean, one that I worried about was, as I mentioned briefly, a consequence of a B-cell immunodeficiency. And that have been most worried about, could there be latent viral infections come out, especially some in the brain. And that has been very rare. So the safety profile has looked quite good there. Now, in November 28th last year, the US FDA put out a warning on secondary lymphomas in patients treated with CAR T cells. So they called them CAR T cell lymphomas. And in fact, this week in the New England Journal, there's a perspective written on that by representatives from the US FDA about this issue. And so far, what the FDA is doing is investigating this more. The incidence of where a CAR is actually in the secondary malignancy is so far only 3 cases have been identified out of about 34,000 patients treated. So it's a very low incidence. And there's some data now that, comparing patients who got CAR T cells or who did not, and then just looking for time, that the incidence is the same. So that people, once they've had one cancer, are at increased risk to get another one. And I think that's all this is. What people haven't talked about is both in Europe and in the US, unlike other cancer therapies where there's no prospective registries, in the case of CAR cells, both the European regulatory agencies and the US FDA require that patients, that there's a 15-year database following patients. So we know prospectively what the incidence of these side effects are. And, we've known for several decades that cytotoxic chemotherapy causes cancer in the survivors. And there's no prospective database to really know with precision what the incidence of that is. But some studies have suggested that people after chemotherapy, such as for ovarian cancer and breast cancer, that the incidence of secondary leukemia can be as over 5% in patients that have myelodysplastic syndromes and AML. So the CAR T cell risk is orders of magnitude less than what chemotherapy does.
Obviously, the FDA's warning made a bit of a splash in the news. Has that impacted what your patients are worried about?
Well, quite frankly, it's been more of an issue on the stock market. I think, it made investors, in the biotechs skittish, so it had a field effect on the, I think, biotech and pharma. But as people are looking into the data, I think it's actually reassuring. We knew that, the question was always what the relative risk was, and there were no documented cases. So that couldn't last forever where the numerator was 0. Now what we have is a very low number, maybe 3 out of 34,000. So I think it's much safer than the kind of therapies that cancer patients have been subjected to before, but it doesn't mean that we can't make it better.
That's fantastic. Are there any other interesting topics in CAR T cells that we haven't had a chance to discuss today?
Well, I think the huge thing that came out over this last year now and was highlighted at the ASH meetings in December is the use of CAR T cells in autoimmune disease. And we have a symposium on that here at CART 24. Professor Mackinson's talking today, and their group from Erlangen showed at the ASH meetings the follow-up of treating 15 patients with a refractory autoimmune disease like lupus, and they had a 100% response rate with treating with an anti-CD19 CAR T cell. And so that's just a remarkable finding. Other groups now have replicated this responsiveness, and where people are getting drug-free remissions in diseases where that's just never happened before. And I looked about a month and a half ago at clinicaltrials.gov, and there are now over 30 trials in the world testing CAR T cells for autoimmunity.
That's fantastic. And it looks like a really bright future for CAR T cells in general.
It won't just be cancer.
Well, thank you so much for your time, Professor June.
Well, thank you.
Thank you to the listeners for tuning in today. It's been our pleasure to have you here.
Thanks. Enjoyed it.